specifically this block. I'll be teaching all of block 1 and a few classes in block 2, but it's kind of the same rules of engagement she gave you. If I'm saying something, if it sounds repetitive, it's for a reason. Okay? At the end of the block, they'll say, oh, he repeats himself all the time. I got it. There's a reason, right? So listen to what I say. I don't teach directly off the slides, but all the information is in the slides. For those of you concerned, because you kind of got used to how Major Hart presented things, like I said, we worked on this together. We write the test together, write any of the curriculum that is presented. She and I worked on it together. That's why you will see a few things dated on the card for PHARM that there's a little star, January 4th. So if you downloaded some stuff, if you're eager over the holiday and checked it out like before January 4th, then you might want to just reload it. Some stuff taken out, some stuff added in. Not major changes, but some key things that we thought were important. So just make sure you do that and not studying the outdated slide deck. Let's see if I can get this machine going here. Am I up? All right. So one of the most important topics we're going to cover in PA studies, and obviously we need out in practice. Hypertension, hugely prevalent. You're going to pretty much see it every day. You might not be treating your patient for hypertension. They may just be there for somewhere else or something else and they have it, or they may be there for something else and don't know that they have hypertension. So you're going to pick it up and then kind of work them up. We're going to talk about those things. We don't memorize drugs, right? We say that. It's hard not to say, oh, I have to memorize all this. Got it, but really, if you think about the mechanisms of the drugs, you think about your patient, and a huge one is the comorbidities, right? What else is going on with this patient? That's going to drive your treatment in hypertension. There's no, hey, Chris Mercer shows up and blood pressure is this number, bam, this is what I give. You really have to look at the whole patient, what else is going on with them. Sometimes it's also like demographics, right? So what race, what age, how are their kidneys functioning? So really, certain drugs for certain patients. That's what you're going to hear me iterate a lot of times. There's no cookie cutter answer, unfortunately. And it is a very dense topic, but if we focus on learning kind of the mechanisms of the drugs, where they act on the body, like is it acting in the kidney, is it acting on a hormone for the brain, is it acting on a variety of different locations that we'll talk about in different systems in the body. But knowing what it acts on, that drug helps drive not only what you'll see with blood pressure that you're trying to lower, but also what if that thing starts working too good, i.e. when we start having adverse reactions. Okay? So the big point is I just want you thinking clinically from the front, and I'll hit you with a lot of clinical pearls. As before, the test will not say, a list of signs, symptoms, lab results. There might be some there, but you don't have to diagnose. We're not going to say, choose, is this chronic kidney disease? You've all got through PHARM I, so you kind of know how the test is presented. If there's a disease process that needs to be discussed or brought into your thinking process or your decision-making process about a drug or a patient, we're going to tell you that they do have or don't have that comorbidity, right? We're not going to have you diagnosing like you'll be doing later in senior semester and also when you get out into your phase 2 sites. So any questions about that? Right, let's see here. We did have a video. Let's see if we can get it going again. If I can time my mouse on the screen real quick.
Everything looks good, Mr. Madden. As expected, right? Does look like your blood pressure is a little high, however. Wait, I have high blood pressure? Yes, but that's consistent with your last visit. We might want to put you on a low dose.
I know it's worse.
No. Come on, those are all men. Well, we finally get to a certain age, we're doing, I know. So, no, I mean, you know, and let's not, I see where you're headed with this, let's not go there, okay? If I wanted my blood pressure to be low, I would simply command my body to be low. Chronic high blood pressure. Okay, well, it is how it works with Dennis Reynolds, okay? And if I'm chronically having high blood pressure, it's because I'm chronically suffering fools who won't listen to me when I say that I can do things. You know what, Doc? I'm gonna take control of this, okay? What's your word down? Because Dennis Reynolds is gonna figure this all out on his own.
All right. So that's what our patients think, right? Our patients oftentimes don't know that they have high blood pressure, or they don't really understand why it's so important that they get those numbers treated, not just the numbers, but what does high blood pressure cause, right? Right on the slide. One of the most important conditions you're going to treat. They feel fine. They don't want medications. They think they can, diet or will their blood pressure down. Go ahead.
Sure, the slides are not.
Oh, okay. Thank you. We good? Okay. So I'll give you a second so you can read it again. But it's a major driver of some really bad disease processes, right? Stroke, MI, heart failure, kidney disease. So our challenge isn't just what drug do we use, but how do we relate to our patients under our care that it matters. We have to convince them why they need to take this medication every day, right? And you're going to see that. We're not like the video. We'll have to figure out the volume thing. But, I see where we're going. I'm not taking these medicines. That doesn't apply to me. So convincing the patient why it's important is going to be half the battle, right? All right, so enabling learning objectives. Big four things, right, you need to get out of this lecture. Properties and uses of medications, the pharmacotherapeutic approach to all the medicines, not just the drugs, but how they work throughout treatment. Because a lot of the drugs that we use in hypertension, it's not just it does something in the beginning and that's what continues to happen. There's actually physiological changes that happen in the body if you take certain medications that we'll discuss that provide benefits in the disease process, i.e. preventing organ damage or preventing progression of disease processes. And we'll hit those pretty hard. Third, big one, right? Select an agent based on patient presentation and comorbidities. Is this chronic, elevated blood pressure, hypertension, or is this a hypertensive emergency? Very big difference in how you're going to treat that patient based on how they're presenting, and, oh, by the way, do they have a kidney disease on top of it, or diabetes on top of their severe hypertension or their hypertensive emergency. So the big one there is hitting the comorbidities. And then, just like you got last semester, the indications, adverse effects, contraindications, interactions, the routes, and counseling. So not much to learn there, right? All right. If it feels repetitive, once again, it's meant to be. These are some huge abbreviations. You're going to see them on the test. You're going to see them throughout the lecture. Get familiar with them. I can tell you, I've been a PA 20 years now. On the exams, if you pick up on the abbreviations, the names of some of these drug classes really help you with identifying what the question is driving at, right? So if you know that an ACE is an angiotensin converting enzyme, then if that's in the question stem, whether that be on our exams or that be on the end of rotation exams or be on the pants when you're out there practicing. If you can identify these acronyms, that drives, okay, so what does an ACE inhibitor do? So what does ACE do? What the inhibitor does? It's half the battle already. You already know that question is focusing in on a certain physiological action in your body where it's happening, and it helps drive the decisions that you make on the correct answers on those kind of questions. So the question stems, a lot of times, if you stop, decode kind of all the acronyms that are in there, that's going to lead you down to the right answer of what the question's getting at. So that's just a test taking hint, don't just memorize the acronyms and the words. Think about what those acronyms are, what they mean. And I'm not going to read them all to you, but those are the main ones you'll see throughout the lecture. All right, major medications we're going to cover today. Like I said, it's not lost on me, this is a huge list. I remember sitting in your seat. It is a lot of things, but if you go at it like learning the classes, learning where they're at, in physiologically, it's much easier to digest and also to figure out the right dosing for your patient eventually, but also what the questions get at on your exams. Those suffixes, huge. Again, right? We're going to talk about certain class of medications, but if you know those suffixes, they're all on exams, right? If you see something that ends in pril, think ACE inhibitor. If you see PINE, pine, calcium channel blockers. There's not many exceptions, and if there are exceptions, I'll bring it up. But these are drugs that you can identify the class a lot of times based on the suffix or the end of the word. So those are the big ones there, but as you'll see, some exceptions, the calcium channel blockers, the non-DHP ones, they kind of one-offs, right? Just a couple of meds there, verapamil, the Altazam. But a lot of them, if you know, especially the ACEs and the ARBs and the thiazides, if you know that suffix, you've got it. And exams love those suffixes. If they give question choices and you know you need to be using a calcium channel blocker, well, you just look for the one that has the right suffix for a calcium channel blocker. Yes. We'll talk about it, dihydropyramine, but we'll talk about it today. So we'll talk about what the class of a DHP calcium channel blocker is versus a non-DHP. All right, so hypertension, right? We have to have a definition. We used to hear out in our guidelines, oh, get it below 140 over 80 or over 90. But that is slowly going down in all of our algorithmic or patient decision-making processes if we're going by guidelines. There was some of you may know, 2025, we just got a brand new American Heart Association, American College of Cardiology, all combined, they all signed off on these new hypertension guidelines. Well, they're at the end of this slide deck. You should be aware of them, but the way the PHARM works is they may or may not make it by the time all the questions are vetted off the brand new guidelines. By the time this cohort takes the PHARM, they might not be tested off those guidelines yet. Just some subtle differences, but basically it's been lowered as far as the threshold for treatment, and the systolic blood pressure now, anything greater than equal to 130, we're going to initiate treatment. And you can see the different classifications there. Lower threshold for diagnosis because that gets interventions on earlier, which saves organs and lives sooner, or prevents or delays those conditions worsening. Diastolic blood pressure greater than 80. If you look at the chart, right, you don't have to memorize the chart. In the test stems, we're going to give you the numbers and say stage 2, stage 1. But if you look at the chart, if the systolic's in one column, diastolic's in another, go with the highest one, right? Once again, all the guidelines are based at intervene earlier. Get the blood pressure down sooner so that the disease process doesn't progress, so you don't start getting end organ damage, right? So the take-home point is threshold for treatment's lower. Now, if the patient has comorbidities, diabetes, heart failure, past stroke victim, that lowers it even more, right? A lot of patients, no matter what their blood pressure is, after they have one of those major cardiovascular events or emergencies, they're going to leave the hospital on a medication because, as we'll talk about later, those medications have been proven to decrease mortality and morbidity in post-event treatment. So, once again, comorbidities drive how we're going to treat our patient. These numbers matter. Why? Because it tells you when you're going to initiate treatment. The guidelines, like I said, I think the bottom of this slide references the 2017. There was a 2022 and a 2025. And now all of the organizations are signed off on the 2025. There's a new calculator. It's called PREVENT. It won't be on the test, but wherever you see the ASCVD reference, so that's the 2017 and later guidelines before 2025. Basically, it's a questionnaire or a fill-in little algorithm, and it's not just looking at what the numbers are, but it helps predict what are your chances of having severe atherosclerotic related event, stroke, MI, those type of things based on risk. And the new one just brings in, the 2025 PREVENT just brings in a few more parameters. It looks at a lot more things than just, age, race, and what type of event you had. So the ASCVD or the PREVENT is basically just a predictor of you having or your patient having an event that's related to atherosclerotic cardiovascular disease. And as you can tell, I have like a really bad northern accent, right? So my southern accent a lot of times actually, some of the words, if I pronounce them different than you've heard before, well, we can all read and look past my pronunciations, but that's the way I talk sometimes, right? I'm from Georgia. So. All right, more aggressive treatment targets, and the ASCVD risk of cardiovascular disease is based on a 10-year chance of having one of those events related, such as stroke, chronic kidney disease, or past cardiovascular events. Any questions about this chart or when we initiate treatment? All right, 2 commonly tested concepts. What's the key in that first paragraph? How many agents? 3. Right, so that's resistant hypertension. The patient is not at goal despite being on 3 different classes. Usually that's going to include at least 1 diuretic. We'll get to that soon. Isolated systolic, common in older adults. It's from arterial stiffness, right? Stiffening of the arteries and the coronary arteries. Systolic pressure kind of goes up, just like the name implies. Diastolic stays normal or sub hypertension classification threshold. Pay attention to pulse pressure. That's your systolic minus your diastolic. Right? Anybody know what a normal pulse pressure is? We say around 40, right? So we start getting worried when you start getting the pulse pressure of like 60 and above. Okay, something's going on physiologically we need to be worried about here. That won't be tested, but it's something clinically you need to pay attention to, right? If you get a wide pulse pressure, you're looking at something's going on in the arteries. And that's usually arterial stiffness. And what does that do? Raises your risk on those screening tools. All right. Before we talk about drugs, let's talk physiology. Right? Every drug we're going to discuss is going to alter one or more of the mechanisms that control blood pressure. So where do we start? We have to understand normally how our blood pressure is regulated in our body, right? How does it work when it's working correctly? Then, when we figure out how it works when it's working correctly, what goes wrong to where now the blood pressure is going up? Physiologically, things aren't working correctly, and where can we intervene in one of the systems that these drugs treats to get us back on track, right? So we're going to talk about the core components of blood pressure regulation, which is baseline is cardiac output. Foundation of everything we're going to talk about after this is cardiac output because of the factors of how we determine it. Blood pressure is your cardiac output times total peripheral resistance. There won't be any math about the blood pressure equation or cardiac output equation. We won't ask you, hey, what's TPR, what's this, and do math. Just know that if you understand the equation, every antihypertensive drug works at one or both of the things that affect your cardiac output, right? So they either decrease cardiac output, they decrease peripheral resistance, or they do both. If you're stuck on an exam question, look at this equation in your mind, write on a piece of paper, very simple, right? And determine what side of the equation are we talking about here. Where are we looking at a change on one of these factors, right? Which part is the drug targeting? That leads you to, is it the total peripheral resistance, the cardiac output, and then knowing how the medications we're going to discuss as we dive deeper affect either total peripheral resistance or cardiac output. It leads you down the road of what the question's getting after. So cardiac output, right, systolic. That's your systolic blood pressure. It depends on your heart rate, how quickly the heart's beating, and also the stroke volume, when it's beating, how much is it pushing out to the periphery, and the venous return, how much is getting back to the heart, right? We're going back to that first semester stuff, right? Basic cardiology, how the heart works. How does the heart get blood to the rest of the body, and how does it return blood to itself? Anything that slows the heart or decreases contractility, so if a drug decreases how hard the heart is pushing or working, then that's going to lower your systolic pressure. Right? You kind of know that. If it's not pumping as hard, with as much force, well, your systolic number is going to be down. That's the whole reason we measure it. So TPR, total peripheral resistance, is mostly influenced by the diastolic blood pressure. And it's driven by vascular contraction, right? Or vascular remodeling or hypertrophy, if you start to get some hypertrophy of the heart, or if you get some remodeling on the vascular itself because your blood pressure's been running super high for a long time. For every kind of action, there's usually reactions in our body, right? So when you start getting kind of chronic remodeling changes on that vascular or the heart vascularity or the heart muscle itself, then that's going to increase the resistance. Makes sense, right? That's why a lot of the first line agents we're going to talk about, ACE inhibitors, the ARBs, the calcium channel blockers, the diuretics, which are all kind of baseline, first line backbone drugs, they reduce peripheral resistance, but all of them do it in a different way. And that's the key, knowing how they act and how they change total peripheral resistance. And chronic hypertension is not just about having tight vessels, right? When you have blockages in there or vascular tightening, it's also structural changes, right? As this heart hypertrophy, as the vessels that feed the heart or return blood to the heart or pump blood to the heart, the coronary vasculature, has there been any changes in those due to the extra pressure and changes that we've had in our bodies over time? So now we're getting remodeling of those structures. You have a question?
Sir, the vascular, is there an optimal time to assess EP of patient?
I mean, you're going to, not really. I mean, the key thing is, it's not one time, right? If you're going to do it, try to do it the same day. Very controlled times, done in the same similar setting at least twice and getting the same numbers. We never say, hey, you need to come in at 10 a.m. because that's when we're going to think. Because everybody, even though we talk about those changes, yes, there's a circadian or circadian, whatever that word is, rhythm to some of the changes in our bodies, but or circadian. They're we don't kind of say that this is the best time to test the patient at night or day. We just try to do it around the same time, kind of close together, and get a few readings, at least 2 readings, very close together. Like you'll hear a lot of times you'll do like a 3-day or a 5-day blood pressure check where you have to go in, have the same kind of, at the same clinic or your same medic or whatever the case may be, wherever your primary care is, take your blood pressure so you can ensure that you're getting it tested under the same parameters, in the same location, by the same people, so that you can say, yes, there wasn't a whole lot of things out there affecting this. This is a true and real number. But no, we don't, to answer your question, we don't ever say, oh, you know, it's lowest at this time or highest at this time, so we want to check it now. Not generally in primary care. We just kind of say, hey, if you did it at 9 o'clock this morning, be back here at 9 tomorrow. Or by, you know, it's at 1400, come back at 1400. So that you can just say that we're doing it under kind of the same conditions around the same time. Because you do have to establish a pattern. Like you don't, your blood pressure could be super high, event driven, and you go in and, oh, well, you have high blood pressure, you have hypertension, here's your diuretic. We want to establish that there is some type of validity to the test, to the numbers that we're producing, okay? Let me skip mine, cursor back here. And the last point, on this next one, yeah, there's 2 different slides there. Okay, there we go. Just make sure I hit everything I wanted to hit here. I talked about the fact that all of those first line backbone medications are going to affect your total peripheral resistance or your cardiac output. They're just going to do it in different ways. So that's where we get kind of really the meat on the bone is when we get into that discussion. Timing of the BP measurements. One thing that I didn't talk about in answering this question was the white coat syndrome. We've all heard about it, right? My blood pressure at home is this, and then I get into the office and the doctor or the PA or the nurse walks in. My blood pressure is sky high because I'm worried about him taking it. So that's what the white coat syndrome is. It's a real thing. Some people do get freaked out about having their blood pressure checked. So, but your fact about is there a specific time? We do want to know if the patient has taken a blood pressure medicine, right? Because if they come in, they're supposed to be on a twice a day ACE or ARB or a diuretic, but they decided not to take it that day and their blood pressure's way up. Well, if you've been treating them and you're trying to see if your treatment is effective, usually that takes a while. It's not an instant kind of thing. It usually takes days, weeks, usually weeks before they follow back up and you see a decline. And we'll talk about how much decline in the time period as we get into specific drugs, but medication timing is a huge one. You want to make sure that if they're supposed to be on medications, that they've been taking it as it's prescribed when you're getting that blood pressure number, or else it's not really going to be very beneficial to you to know how that medicine is affecting the patient because the numbers that you're seeing aren't medication driven. They're back to being hypertensive without any meds on board. So, all right. So now we're moving into everybody's favorite, some physiology, right? So you probably hit the RAS system back in A&P at some point, maybe some pharmacology last semester, right? RAS system familiar, up and down or left to right? Okay. All right. It's one of the fastest regulators of blood pressures, regulatars of blood pressure in our body, right? It happens pretty quickly. When it's activated, and it's pretty easy on the slide, right? Because the green arrow is going up. We're now talking about what happens normally. Like, what is the RAS system there for? How does it function? Because then when we talk about dysfunction, that's how we talk about bringing meds on board. So you have to know what ACE is, for example, to know that an ACE inhibitor inhibits what ACE does. Makes sense, right? So go back, if you're revisiting this, make sure you have a strong handle on what the RAS or the RAS, once again, however you pronounce it. It'll say RAAS on the test, so however you want to pronounce it's fine, but I say RAS. So the RAS system, what it does, stimulates the heart. How? beta 1 receptors. Important, because we talk about beta blockers. Well, there's beta blockers that hit beta 1. There's beta that are hitting beta 1 and some alpha receptors. So beta 1 receptors in the heart. Alpha 1 in the vessels, vasoconstriction. Beta 1 is also in the kidneys. So what are the kidney effects of the beta 1 receptors? If the ROS system is activated, the sympathetic nervous system is firing, blood pressure is going to always go up or always go down, normally. Up, right? Just like the chart showed, up. The entire system is a negative feedback loop, and we'll get into the deep dive here in a second, things that aren't that fun to study, but you need to know when the sympathetic nervous system is triggered to fire, it's saying blood pressure low, make high. Give us our blood pressure back, right? And so when your body senses through a bunch of different receptors that we'll deep dive into that the blood pressure or the kidney flow is too low, sympathetic nervous system kicks in, let's get the blood pressure back up, right? Whether you're bleeding out or whatever reason why volume is decreased to the kidney, sympathetic nervous system, the ROS part of the sympathetic nervous system, specifically, mainly kidney, but some lungs and some liver involvement, is going to say, get the blood pressure back up. This is really just showing how interconnected everything is on this slide. What does sympathetic activation do? You had it last semester, right? You had sympathetic, parasympathetic. Cardiac output increased. Peripheral resistance. What happens there? Everything clamps up, right? Because you're getting blood to the organs quickly. Renin release. Renin is a huge one. We're going to have 2 slides just devoted to renin. This is just a basic overview at this point. But that renin being released is what's going to fire up the ROS system. Now that's going to increase vascular tone, and it's going to increase our blood volume by putting those fluids back into the system instead of excreting them out, right? Through the kidneys and then through the urine. So this slide kind of helps me visualize how blood pressures work at many different points of this cascade, so to speak. Multiple points in the cascade are hit by different drugs. All right. Long-term regulator of blood pressure, most important player, ROS. That renin, angiotensin, aldosterone system, once again, if you know the abbreviation, don't just know ROS or RAS. If you think about what that acronym is, you already know the major players in what we're discussing. Regulates sodium, regulates potassium, and fluid balance. Influences vascular tone. Yes, I've repeated it a couple of times, that vascular tone coming from the ROS system activation. If there's a system, when we talk about hypertension, that's going to be on your end of rotation exams, that are going to be on our exams, that Major Harder and I are going to prepare, or when you get out and do the PANS, they're going to ask you about ROS. You're going to see it. You will never escape the ROS system. As long as you have a PAC behind your name, it will be important to you. Trust me, because it is complicated. And every time I do a PAN read, guess what? I see questions about the ROS system. Maybe not directly, but certainly about medications that influence the ROS system. All right. Everybody's favorite part. We're going to slow down and talk about ROS, right? And all the different players involved in that big cascade that we just discussed. Everything starts in the kidney. Think of it that way. Juxtaglomerular cells. They're baroreceptors. What's that mean? They respond to pressure in a negative feedback loop. So really they're responding to what? Increase or decrease pressure. Right, negative feedback. They're activated when there's not enough pressure on them. And then they're gonna kick out a chemical, renin, like I discussed. Where the juxtaglomerular cells live won't be on your test. You have to own it. That would have been on A&P1, right? Afferent arterioles. But it is important to know that because when we get into some drug classes, we will talk. Does it affect afferent, efferent, front side, back side, the giving or the taking? Like I said, the baroreceptors, they sense through decreased pressure. That means there's less, because they're an afferent arteriole bringing blood into the kidney. What does that mean? That means there's not as enough blood coming into that afferent arteriole. So we need to make more pressure. We need to perfuse these kidneys better, and so they kick out renin. So not only they sense pressure, so decrease in pressure, they also will fire off if they sense decreased sodium out in the distal tubule. Remember that from way back, 2 semesters ago? Or increased sympathetic stimulation. So if the sympathetic nervous system's fired off, it's going to pick up on those hormones too, and we'll get specific into which ones, but that's also going to cause the release of renin. So it's the kidney's way of saying, there ain't enough fluid coming to me, right? So blood pressure's too low, those cells kick in, we got to get some renin on board. Renin itself does not really affect blood pressure directly. It activates other things, or other sensors, which we'll get into, that will then specifically affect blood pressure. Because anybody know what renin does? It may be on your slide, I'm not sure. Angiotensinogen, I heard that word, becomes, and who does it? Renin. Right. So renin's just a player in the sequence. Renin kicks out there, and then where's angiotensinogen come from? Angiotensinogen. Where does it come from? Right. Okay. So now angiotensinogen comes out. I know I murdered it. I told you my George accent. But you can read it. Angiotensinogen. If I slow down, I can get it out. All right. It's released from the liver. Renin is released, right, from the juxtaglomerular cells. It cleaves that A word that ends in N. What does angiotensinogen become? 2 or 1? 1. Does 1 do anything? Becomes 2. Right? It doesn't do anything. There's an action that takes place. But in test questions, sometimes they say the least biological activity. If there's a list, it's going to be angiotensin 1. It's an inactive precursor, is the technical term we use. We good? Moving on. Okay, so then the big action. Non-biological active angiotensin 1 becomes angiotensin 2, which has direct effects by what? What's converting 1 to 2? Making it active. ACE. Right. The angiotensin converting enzyme. ACE. So what do you think an ACE inhibitor does? It stops that. Right. So if you know and can think through that process, there are no gotchas. You can think about what an ACE inhibitor will do because you know we already talked about that entire cascade that happens mainly due to angiotensin 2. So it goes through the renin, tenogen to 1. It's activated by ACE to become 2, and then we start to actually get our changes. So if you know what angiotensin II does, and you know that ACE is the conversion, the catalyst from 1 to 2, then you know what an ACE inhibitor is. Where's the ACE at? Where's ACE? All over, majority. Where's most? Lungs and kidney, kind of right up there with it. But yeah, it's in the smooth muscle, kind of all over, right? Multiple pathways. So, angiotensin II, has it increased blood pressure? Should be on your slide, right? Like the Schwartz bullet down, right? Vascular smooth muscle, contracted. The adrenal cortex is also stimulated to release what by angiotensin II? Aldosterone, which is another major player in our blood pressure system, or the ROS system. 2 is also going to increase sodium reabsorption in the kidney. Heart rate's going to go up. All these things aimed at doing what? Getting more pressure to the justoglomerular cells in the afferent arteriole of the glomerulus. Everybody still with me? All right. So if you think about everything it does, there's a few more things, right? ADH released from the brain, antidiuretic hormone. What does antidiuretic hormone do? Well, it's anti-diuresis. So instead of peeing it out, you want to keep it in. It's anti-diuretic. So all those things happen because of angiotensin II. So if we talk about the broad effects, we got them. And now if we block that, we pretty much can predict what will happen by blocking the conversion of angiotensin I to II with an ACE inhibitor. Remember, in all this, we're talking normal stuff. So water follows sodium. If you decrease the reabsorption of sodium in the distal tubule, well, you have more sodium in the system, so water's going to stay with it, right? So blood pressure goes up. Water's going to follow it. Expanded blood volume increases blood pressure. Okay, and we'll talk a little later about the ACE inhibitors and the ARBs and what their effect is on potassium too, because there's some changes that happen with excretion of calcium that are changed with an ACE and an ARB, which can lead us to get hyperkalemia, too much potassium in our blood, which can be a bad thing at certain levels. With that a little harder, but aldosterone plays a key in that. This is just a visual of everything I just talked about, or that I highlighted. There's a few extras, but you can see there, we're talking about where some of the medications for hypertension, where they act in the ROS system. Remember that the ROS system, most influential contributor to long-term blood pressure regulation. Controls your volume, vascular tone, sympathetic activity. And so that's why your ACEs and your ARBs are going to be cornerstone therapies. Especially if they have comorbidities like diabetes, CKD, which is what? Chronic kidney disease, or heart failure. Okay. Bread and butter. Money slide. Primary hypertension means my systolic is above,
130
at or above?
130 over
130? Yeah. Diastolic? Got it. Okay. Or, there are blood pressure medicine already. That was the other video I almost showed. It's pretty funny, a doctor talking to his patient back and forth. One of these characters where they play themselves, and it goes back and forth. But so it's a doctor talking to himself, pretending to be a patient, framing back and forth. And he's like, "Oh, I see you have high blood pressure." "No, I don't." "No, you have high blood pressure." "Yes, no." "Yes, no." back and forth. And he goes, but you're taking these medications. Yes. So you have high blood pressure. No. I take the medication so I don't have high blood pressure. Right? So you have to know what the patient's taking and how they're being treated, because as we started with the very first video, patients are not going to want to say, oh yes, I have high blood pressure, oh yes, I want all these medications. It's a lot of patient informing and making sure they're on the same sheet with them and monitoring them once we have all these medications, right? So those are your big classes. Stage 1, we talked about the atherosclerotic, CVD, or risk, cardiovascular disease risk. That's the old terms. You'll see it called prevent. Phase 2, you're probably going to see both. That's why we left a slide in at the end, or a couple of slides on the 2025 changes. Because that risk, they give you a percentage that's like the cutoff of, oh, if it's below 10, just lifestyle, diet, and exercise, limited salt, that kind of thing. Or if it's above on the ACSVD, then we move over. But what we need to know is the backbone, when you start treatment, is right there. Those 3. Thiazide, ACE/ARB, or calcium channel blocker. Stage 1 equals how many drugs? It says it on the slide. 1 is 1. Is an ACE combined with an ARB? Is that number 2 saying give an ACE and an ARB? It is not. That is not a good plan. You will not ever combine an ACE and an ARB. It's an ACE or an ARB based on compelling evidence, right? So we'll talk about compelling evidence when we talk about ACE and ARBs. We will say, what's compelling evidence to use an ACE versus an ARB? Well, if they are allergic or have a negative response or one of these bad effects from the one, then we try the other, or vice versa. Or certain disease processes which we know the mortality or the morbidity benefit is better for that specific comorbidity, ACE versus ARB. But you will not combine ACEs and ARBs. We'll hit that a little harder later, but I just want to make clarification on the slide. That is one of those 2. And then there's certain comorbidities, there's certain genetic profiles, that different things that we say these work better or don't work better for. Stage 2. Well, guess what? Same thing. Stage 2, 2 drugs, right? And then pregnancy, our special pops, there's going to be those 3 drugs really are the only ones you're going to see. We'll talk about why. And then you remember we talked about that just isolated systolic calcium channel blockers work best. We'll talk about why. Most are going to start on 1, right? Most are also going to end up on more. You, at some point down the road, they're probably going to be on more medications and move into stage 2 or even worse. But what we're doing by early intervention and what the new guidelines are doing are saying if we intervene earlier, we can prolong that or prevent it as much as possible, right? That natural progression of a chronic disease. By definition, it's going to get worse, or it wouldn't be a chronic disease. And then second line agents, specific indications or resistant cases. If you know these, if you can take this one slide and make that the basis for how you approach your studying, it's a good starting point. Because then you know what the exceptions are. All right. This is just an overarching, right? We mentioned it earlier when we talked about the Ross system, how it is a cascade affecting numerous different locations and different receptors throughout the body. Well, the backbone, as Major Hart likes to call it, we just had on the slide, the backbone therapies work in different ways, like we mentioned. Diuretics reduce sodium and volume. We already said that, but water is going to follow salt. So that's how the diuretics work on that basic principle. We'll get deeper on that. ACE and ARBs, we talked about it. So they're going to reduce that angiotensin-mediated vasoconstriction and volume expansion. So what system are they working on, ACE and ARBs? As an overarcher, where do they work? The ROS system, yeah, the RAS system, ROS. However you choose to pronounce it. And then the anti-adrenergic agents, well, you know what it does, then you know that if you're anti-adrenergic system, then you're reducing cardiac output and reducing peripheral resistance. A lot of times your exams are going to match mechanism to clinical effect. Mechanism of the drug, what's the clinical effect? So if you understand it, you can link the two. All right, diuretics. It's a deep one. Shall we take a break? All right, 10 minutes. Be back at 2 after 2, 14 and 2. And I'm up here if anybody has any questions.
Wait till 2026, baby.
Hey, sorry? Hey, so
I think so.
There's the single amount of words I wrote. With the Harry Potter sorcerer's stone.
It's growing. It grows so fast.
Also, the Hobbit. I wrote this one.
Which active digest?
They're on stage 2, they gotta have it.
That's how it goes.
Oh,
Hell yeah, look at all the aces. Yeah, it's 10 electrodes.
oh, yeah, yeah.
There's 4 electrodes. So we have 2, 3, 1. Yeah. Yeah. That's 6, 3, 5, And you spell ABR and I don't know, dude. Like, I feel like in the gym I have to, and I'm like,
I finally took a shower, then
negatives. It's the positive. It's the right on.
Smells like popcorn.
Oh, I'll show you. This is my first popcorn for a second.
This is my second one.
It's snappy.
It tells you it's the positive. Right on. That's for ABL. ABL, or yeah, your ABL sits in your left arm. So your left leg is the bottom part.
I think that's why it's on the screen side by side.
It puts the two negatives. It doesn't get around. The machine doesn't treat negative charges. It still goes into the APR. It's still the positive. No, it's only one positive, two negatives.
I am not even.
Just try it.
Thank you, Alex. We love it. Would you like some?
Oh, that's right.
Soy. Yeah, I want it with soy. This is not one of the biggest things.
No, is it good? No.
March, February, I mean,
Yeah, it'd been nice to have gotten.
Yeah.
I've gotten a long break. Next break was 15. It'll be like, feel like we're right back in it.
Yeah, but the
No, we're buying it and liking it.
I was like,
I didn't learn anything.
That's why we blood on there. Somebody probably died because you put it on my desk.
Yeah, Thompson, you know what Thompson
it only adds the, yeah, it's like, yes, it's negative.
Oh, okay.
Yeah, that's the machine. That's the
If you stay with one,
yeah.
okay.
So look, lead two, right? No, it's it's look. It's part of the plan. Really? Didn't you make it? No, it's not. The camera's down here. It's not coming from the way on. Yeah, all the impulses are listening to the top of no, it doesn't. It really doesn't. It still counts as this is just instead of here, right? Because look, this is the camera, right? This is the plus this
Purple, right?
This is
They were in Subcon, right? Yeah, we permanently still play. Whatever SoCon is, it's like the one that like will get bid if they win the conference, they'll get like a bid into like the big one play. Yeah.
This is just that's it. That's why he creates upside down. Yeah,
My whole family was Ohio State, so they were all like, they got beat by. Yep. Yeah, those big schools that like to just change quarterbacks to each other, you know? Yeah.
Alright, let's go ahead and look back at.
Did you take that ball from up there?
I'm trying it out. Seeing how it goes. I'll leave my written assessment for you.
So just so you're kind of tracking, if you pulled up the whole slide deck, obviously we're not getting through antihypertensive today, right? So we'll knock off, and then tomorrow I'll probably do an hour, the first hour of finishing up hypertensive. I've got some checks on learning that we'll do so you can kind of get used to the style of questions that we're writing for this exam. Shouldn't be anything new to you. And then we'll pick up with diuretics, which is great because we're hitting diuretics pretty hard now, right? Here we go. But when we start talking about diuretics as a class, not just in hypertension, it kind of opens up some different classes of diuretics we have to talk about. So today, it's on the slide. Specifically what? Thiazide and thiazide-like. Specifically in hypertension. Keep that in mind. So when we get to this tomorrow at 1400, about this time tomorrow, thiazides is already going to be presented for hypertension. So then we're going to talk about maybe some other uses for thiazides, but then we're also going to hit the loops. We're going to hit some of those that are hormonal acting. So just keep in mind that a lot of, you'll see some little mnemonics. It says something like A2D3, right? Just think about when it says diuretic is your D in that mnemonic. If we're talking hypertension, then we're talking what? Thiazide and thiazide-like diuretics. Doesn't apply for all diuretics. So if we talked about that backbone, right? So if we're saying choose one from each of these classes and one of them should be a diuretic, one of them should be a thiazide or thiazide-like diuretic. Don't get confused and start thinking, oh, well, all I need to, that's a diuretic. Well, that's spironolactone. It's not a hydrochlorothiazide. Very different effects. So we clear on that? I just don't want people out there going, oh, I'm just going to remember diuretic, and I'm going to pick diuretic. It ends in HCTZ or has HTZ at the beginning, and that's what I'm going to choose. But for hypertension, we're talking thiazide and thiazide-like. Why? They are the best tolerated across the board. Better than ACEs, better than ARBs, better than calcium channel blockers. And we'll talk about some of the side effects of those other medications. Usually first line, unless contraindicated. That's why they're over on the far left of that little tree that we talked about. Stage one drug, which one am I going to choose? Because I like to make it easy on myself. Probably a thiazide or thiazide-like. There's your three main drugs. Kind of easy to pick hydrochlorothiazide out of the lineup if you're looking for a thiazide diuretic. Chlorthalidone, unfortunately, there's no suffix that's going to drive you to it. You just got to memorize that drug name because there's lots of things that end in D-O-N-E or O-N-E. So no help there. Metolazone, no. We're talking about specific uses. Unfortunately, this is one of those cases when you think about thiazide or thiazide-like, these three, well, if it's not hydrochlorothiazide, then you just have to know that drug name. Doesn't fit into our suffix rules neatly. Okay, we talked about them already. What do? Inhibit sodium chloride reabsorption in the early distal convoluted tubule. Reach way back into A and P. Think about the distal convoluted tubule. So, back in the distal convoluted tubule, these drugs are going to inhibit sodium and chloride reabsorption. Right? Which, when we talked about the RAS system, what does it do? The opposite. It accelerates sodium reabsorption. So in that early distal convoluted tubule, this picture shows you, if you'll see the numbers on the bottom left, and you see where these medications act. The important thing to visualize in this slide, the further left you move on the slide, you see where the numbers are. Well, if that drug's acting further left, guess what happens? Things are going to be counteracted further down. What does that mean? The further to the right on that slide that drug is, that there's less chances of it being reversed or compensated for later down the line. Because you can see what's happening. You don't have to memorize all of it. You already had to do that for A and P. But you can see what's happening at all those different locations that I've marked there with the different drugs. Just know that the further on the right, the less chance there is for the kidney to compensate for that change and readjust, right? May help some of you visual folks just thinking, oh, well, if I'm given, some of those before the loop of Henle, guess what? Some of their actions are counteracted down the line because the other enzymes are acting there, so they may counteract some of the effect. But if you see the diuretics, specifically thiazide and thiazide-like, pretty far down in that chain. And there's not a lot of side effects. They're cheap, and they increase mortality and morbidity, so use them. Why do we use them so much? Strong outcome data. What's that mean? A lot of smart folks have done a lot of long studies on these, and they've been around forever, so it's outcome driven. If it has good outcomes, then in medicine, that's our validation for we need to use it. There's some specific lowering of the systolic and diastolic that we're going to talk about. Thiazides, systolic drop by about 15 to 20 millimeters of hydrogen. Is that like an hour after you take it? Is it a day after you take it? All these are weeks, right? Your follow-up on this is a slow game. This is a very slow game. You're going to start low, go slow, and follow up and make minor adjustments. You're not going to have a chronic hypertensive patient walk in your office, you diagnose, you find them. Oh, what does the American Heart Association say is your stage 3? Here's your 3 drugs. You should be good. You got to start low, go slow, and follow up. And oh, by the way, get some labs. Because if they're affecting electrolytes, which kind of runs our heart and our brains and the rest of our body, we're going to make sure we're monitoring those electrolytes, right? So diastolic, about 8 to 15 milliliters of hydrogen. The standard for these changes, 4 to 6 weeks. I don't even know if it's on the main slide, but 4 to 6 weeks. So that's why you're not going to have a patient follow-up that you just put on a new diuretic within a week. You're not going to see as much. 4 to 6 weeks kind of the follow-up. Guess what they do? Outcome data driven. They have been shown to reduce strokes. It's a big one. I think our patients appreciate that. Reduce major cardiovascular events, right? Reduces overall morbidity and mortality due to hypertension. That's outcome driven. They reduce morbidity and mortality. That's important. Some drugs affect symptoms, lower the blood pressure, and that's great. We need those too. These medications are outcome driven, right? We talked about the screening tools is going to predict your chance of having a major event due to atherosclerotic cardiovascular disease. Well, if we're screening for it, why not use a drug that shows it decreases the chance of it? If you're asked the best long-term outcome data, hint, hint, on a test, probably not mine, but maybe. But certainly I've seen this on the pants or the pantry through the years. Thiazides, in the conversation, point blank. Outcome-driven thiazides are in the conversation. Limitations. Okay, we talked about where they worked. Where do they work? Out here in what part of the kidney? Distal convoluted tubule, right? Okay, so if my kidneys aren't functioning well, do you think that will alter how the efficacy or how well a thiazide diuretic is working? 100%. Those numbers on the slide you need to know. Those lab data values, right? Creatine clearance and the creatinine. So if your serum creatinine is greater than 2.5, probably not going to work too well. Your kidneys aren't functioning that great. Or your creatinine clearance is less than 30 milliliters per minute. And the creatinine was in milligrams per deciliter. I'm not sure if that's on your slide. It is. Okay. You'll get this tomorrow, but coming attraction, then you probably want to use a loop, but a loop diuretic. That's just a coming attraction for tomorrow. I know you're excited about it. All right. Exam questions. If you have a patient with chronic kidney disease, CKD, there's that comorbidity and hypertension, and you're giving them a thiazide or thiazide-like diuretic, you come back in how long? 4 to 6 weeks, and it's not working, start looking at these labs, right? I already gave you the hint. Chronic kidney disease. Probably that thiazide isn't working because their kidneys aren't working that great, as evidenced by the labs that we just discussed. Any question about that? Okay. Most common adverse effect, hypokalemia. 10 to 15% of our patients are going to develop it. Monitor it. Monitor the potassium. 2 to 4 weeks. Well, probably if you're just bringing them back in, it's probably going to be at that 4-week area. And then once you're stable, about every 6 to 12 months. If the potassium is below 3.5 milliequivalents per liter, you're going to use a potassium supplement, or another coming attraction is going to be a potassium-sparing diuretic. So obviously that's a different class of diuretic than thiazide or thiazide-like. Just like loops are a different class, then potassium-sparing is a different class. And we'll talk more about that to come. What happens with hypokalemia? Anybody, everybody? What's bad juju from hypokalemia? Okay, so heart arrhythmias. Yep. Whether that be torsades, AFib, VTAC, you name the big guys, the big players in arrhythmias, they're all there. PVCs, not as dangerous, but what else? Because it affects us neurologically too. Numbness, tingling, muscle weakness. All right, that won't be on the exam, just probably a reach back to something you were taught at some point, I would think, if you've been talking about electrolytes already. Okay. Can also get hyponatremia. Obviously not as frequent as the potassium changes. On the hypokalemia, hyponatremia, a lot of times that's your older population. You can also get hypovolemia, decreased volume, because it's going to trigger some ADH release from the brain. What did we say ADH was? Anti-diuretic. So if it's anti-diuretic, then you're becoming water overloaded because you're not diuresing. Your brain's releasing something that says don't diurese that much. Increased thirst, you can get a hyperuricemia, the last one on the list. It's important. It will be on a test. You will see it at some point. End of phase 2, end of rotation, PANRE, what is it, 15 or 16 days from now, you'll see it probably. Hyperuricemia. Gout attack, not fun. So thiazides are going to increase your uric acid levels because they're competing for excretion from the kidneys. So your uric acid retention is going to go up. Well, if you're holding it in your system instead of excreting it, it's got to go somewhere. And in gout, it goes to where? Joints, but normally, yeah, the great toe, but joints. And it's no fun, and you don't want it, and you definitely want to monitor your patients to make sure that they are not going to have a gout attack. Okay. Also, we're still talking diuretics, thiazide diuretics. Top of the slide, in case we're getting lost. So also can cause hyperglycemia. It's a big one. Comorbidity, right? Your diabetic patients, because the thiazides can impair insulin release and glucose uptake. We're not going to get into the pathophys or the phys of that, but you need to be aware that the thiazide diuretics can impair insulin release and glucose uptake. So what does that mean? Real world, your patient who's hypertensive and diabetic is now all of a sudden starting, once they've started thiazide, their glycemic control is out of whack, right? What do? We already mentioned it for all of them. Start low, go slow, right? Start low, go slow, 4 to 6 weeks, measure those labs again, see where we're at. Thiazides also increase calcium reabsorption. Much like potassium, when we start getting hypercalcemia, not fun. You can get to levels where things can happen. It's also a good effect if I have a comorbidity like kidney stones. So I've got kidney stones in my kidneys, and if I'm now going to take a medication that is going to increase calcium reabsorption, maybe getting a little bit more calcium in my blood, but now reabsorbing it for the kidneys, so my kidney stones may get better. However, if you have too much calcium in your blood, what does that cause? Hypercalcemia. Arrhythmias is back in play, just like we just talked about. Confusion, fatigue, some neurological changes, muscle weakness. Remember all this? Dig way back for calcium and hypercalcium versus hypocalcemia. Muscle weakness also affects your GI tract. Frequent urination, thirst. I'm not going to ask you all those. I'm not going to ask you on the test. We're really just going to say contraindications or some adverse actions that can happen with these thiazides for diuretics, and that's going to be hypercalcemia, hyperglycemia, and the slide before it that we talked about. Volume depletion makes sense, right? we said how it works. So if we're now getting rid of more salt, water follows salt, what can happen? Too much of a good thing. Now we get hypovolemic. Opposite. We went too low. We pushed out too much fluid. Let me see. Everybody knows my damn code now. I missed it. Okay. So, too low of volume, what are we going to get? Y'all test for it, right? When you test blood pressure, somebody's lying down and they sit up. What's that called? Yeah, or you stand up too quickly, you see the position. So, yeah, you can start getting changes in the volume and you get orthostatic hypotension. Change in position drops the blood pressure because of a decrease in volume. Lightheaded, erectile dysfunction. Some patients may come in complaining of it after they started on a thiazide. So patients are symptomatic. The take-home point is, think about their volume status, right? If we got them on such a high of a thiazide or thiazide-like diuretic that they're not in the fluid in their system. So all the signs of hypovolemia and then build up, because you have less excretion of it, a build up of some of those enzymes into your minerals rather into your blood, which at high levels can cause the things I discussed. Sulfur sensitivity is important in this one. Not an absolute contraindication, but you want to keep it on your radar if your patient has a sulfur allergy. It's something that you want to monitor and think about. Is there something else you can use if they have a severe sulfur allergy? May develop an allergic reaction. So not an absolute contraindication, but it is worth considering since there's a sulfur compound in the thiazides. So just caution there. All right. Moving on. We hit thiazides, we hit the diuretics, thiazide-like. Now we're moving into ACE inhibitors, which we said operate where? Now we're in the RAS system, right? And there are some changes with the thiazides, diuretics, but these mainly operate in that RAS system. They don't just lower the blood pressure. ACE inhibitors, once again, positive effect on end organ, right? They protect heart, they protect kidneys. Very important caveat for the ACE inhibitors. What does that mean? Now we're not just talking about hypertension for them. We're not just giving medicine to lower blood pressure, but it's disease modifying, right? It's protective, renal protective and cardioprotective, not just your symptom control. So backbone of therapy, we said ACE or not and. So hydrochlorothiazide diuretics or thiazide-like. Now ACE or specifically we're talking ACEs. Everybody sees it's underlined for you there. How do you pick them out of the lineup? Prill. You see Prill, it's an ACE most of the time. There's some caveats. In red, you'll see the enalapril IV only. The stars indicated for heart failure. Another coming attraction. We'll mention it today a little bit, but that's a coming attraction in about 3 lectures. Heart failure. But you're already going to have ACE inhibitors and kind of have an idea of which ones they're starred, and as the slide denotes, indicated in heart failure. So you pick them out of the lineup by Prill. Don't try to memorize every drug. Be able to pick them out of the lineup and know what their indications are, contraindications are, drug interactions. Know that some of them can be used in heart failure. If you want to get ahead of the game, the ones that are started, they're there for heart failure, you'll be ahead of the game next week. A lot of times on that right side, you're going to see the combination. Why? Because if someone is not in stage 1 and they need 2 drugs, well, compliance is much easier if I take one drug that has 2 different compounds in it, an ACE and, you guessed it, a diuretic, specifically a thiazide-like or a thiazide diuretic, like hydrochlorothiazide. What does this do? Improves control because you're taking one pill. It increases adherence, balanced, right? I'm more likely to say, oh, I'll take this one pill, than if I've got 10 different bottles of things I've got to sit here and take. So it improves adherence to the medication. So your pill burden is down, right? And you'll see when you start treating patients, a lot of times we talked about this comorbidity, you know, they have overload, they have all these different medications they're supposed to take, and all these different disease processes. It can be overwhelming. So anything you can do to increase or ease their ability to treat their condition, we try to do it, right? Because we know that these medications are going to decrease mortality and morbidity down the long run. So combination therapy is usually what stage? 1 or 2? Right, because I can't combine things in stage 1. I can take it away and give another, but I can't combine things because by definition, that's stage 2. Or just if one thing isn't enough, right? They're not controlled on the one medication you chose when we're looking at the far left of that slide. Probably super common medications. You're going to see these in practice. People on them all the time. Okay, we already hit it. What does ACE inhibitor do? Well, first, what does ACE do? ACE converts 1, which is super biologically active, right? No, it does nothing. Does nothing. But 1 to 2 is done by the angiotensin converting enzyme, and then we're going to block that with our ACE inhibitors. Produced where? Where's ACE produced? Lungs, and we talked about the kidneys, yeah. Predominantly lungs and the vascular endothelial cells. I think we hit that one last time too. So we're going to, by using an ACE inhibitor, opposite of what we said that angiotensin II does. If it vasodilates, well, now it's going to vasoconstrict because it's not on board. We talked about increasing aldosterone from the adrenal glands when our ROS system senses that our blood pressure is too low. Well, if we're blocking that biologically active hormone or enzyme, then guess what? Opposite. Now we're not going to release as much aldosterone. We're not going to release that ADH that we did in the beginning to hold fluids. And we're going to decrease sympathetic output. All by knowing, way back 5, 6, 7, 10 slides ago, however it was, what ACE does, or specifically what angiotensin II does. Well, if you know that we're blocking the enzyme that converts 1 to 2, well, then everything it does, an ACE inhibitor is going to keep it from happening. Too easy. You have to learn one thing and then say, oh, well, it's inhibiting that. Opposite. I'm not getting little looks like you think that's too easy. But you'll get it. If you think about what's happening physiologically, you'll get it. But, bottom bullet, you're also going to increase ACE inhibitors are going to increase bradykinin levels. Double-edged sword. It's important for vasodilation, but there's some key side effects we're going to talk about with bradykinin in some future slides. So this is the same slide we talked about earlier for you visual folks. Just a pictorial of that same kidney and the ROS system and normal activation, but then we get ACE blocked by an ACE inhibitor showing that preventing of angiotensin 1 converted to angiotensin 2. So everything down river of angiotensin 2 doesn't happen. Aldosterone isn't released. Vasoconstriction isn't released. That reabsorption isn't happening. If you're a visual person, this really helps. Okay, well, if ACE inhibitors block that, then everything downstream of it, bottom third of the slide, doesn't happen. Because it happens normally with angiotensin 2. We tracking? Okay. ACE inhibitors primarily reduce peripheral vascular resistance. But they do it without increasing heart rate or contractility. I would say that's important. They're going to reduce peripheral vascular resistance, but they're not going to increase the heart rate or how hard the heart is pumping, i.e. the contractility. They're going to reduce what in our big equation, right? Preload, afterload, cardiac work. So guess what they're helpful in? Coming attraction. We already talked about it. Heart failure. Heart failure. Why? As we just said, they're not going to increase the work of the heart, but they're going to reduce peripheral vascular resistance. So works pretty good in heart failure. My failing heart doesn't have to work harder, but I get decreased peripheral vascular resistance, and I still get good perfusion with no effects on the heart. Well, no effects on heart rate and contractility. We talked about bradykinin, our friend or foe with ACE inhibitors, right? So bradykinin is going to, ACE is going to break it down. ACE is responsible for breaking down. So if ACE is responsible for breaking down bradykinin, what does an ACE inhibitor do for bradykinin? Doesn't break it down. So what does that mean? It means we got higher levels of bradykinin. Bradykinin is going to rise with an ACE inhibitor. And so what does bradykinin do? It stimulates nitric oxide and prostacyclin, both vasodilators, which sounds good, right? We're going to vasodilate. That's kind of what we needed because we have hypertension. We're using ACE to treat hypertension. But we're increasing that bradykinin to the point to where you may get the worst effects, the side effects. Everybody know what that is? Have you heard before? So you can get severe ones, angioedema, right? We're going to show you some slides. But also that dry hack, that dry cough. That's coming from bradykinin. So it's a trade-off. Bradykinin, friend or foe. Helps vasodilate through prostacyclins and the nitric oxide. But bradykinin levels get up too high because the ACE is no longer breaking it down. Then we can get these side effects, the dry cough and the angioedema. And I think, yeah. So when do we use the ACE inhibitors? We already hit on it a little bit. Diabetes with proteinuria. Compelling indications. That's how it's going to be termed a lot of times. Is using ACE inhibitors if you have hypertension and a compelling indication. Diabetes with proteinuria is compelling. Chronic kidney disease. Heart failure with reduced ejection fraction. We'll see it abbreviated HFrEF. But heart failure, reduced ejection fraction. Stroke, history of a stroke. High coronary disease risk. How do we calculate that? ASCVD or prevent. Remember way back when, an hour ago, we talked about it? If you see these comorbidities, think ACE. These compelling indications. Hypertension with diabetes, proteinuria, chronic kidney disease, post-MI, post-stroke, a high coronary artery disease risk. Now, you will see, and I'll mention it here because it's probably still in the testing materials. Into rotations, phase 2, maybe PANTS. There's some debate about ACE inhibitors and its effect for African American patients. It used to always be taught that the ACEs didn't work as well. I think it's related to the functioning of the ROS system a little bit differently in the African American population. So it's still out there. However, the newer guidelines are kind of saying it's not that much of a thing. But I bring it up because you still might see it on the test. ACEs maybe not as doesn't have the same efficacy in the African American population. thought to be due to a less active ROS system. But they're still first-line medications, right? But normally, we're going to combine them with some other medications. So ACE inhibitors are renally excreted. So renal function matters here too, just like we talked about with what? Hydrochlorothiazide or thiazide-like diuretics, right? We talked about bradykinin, friend or foe. That's what gives you that dry cough. Up to 40% of patients. So almost every other patient that you put on an ACE inhibitor is going to get it. It's because of bradykinin. Way less prevalent is the angioedema. I would much rather be the guy on the top than either of these two individuals on the bottom of this slide. Because angioedema is rare, but it is life-threatening. If a patient has angioedema, no races, and caution with ARBs, which we're going to talk about. But you don't have a patient with angioedema and say, let's just try this other ACE from that long list. This also ends in PRIL. Let's put this on board. Absolute contraindication if you have angioedema from ACE, right? And then caution with an ARB, because they're very similar, just at different points in that little cascade. If I'm coughing, just switch me to an ARB, right? If I have angioedema, definitely don't give me another ACE, and be very cautious about giving me an ARB. We clear on that one? Absolute contraindication if they've ever had angioedema. Obviously, you're going to say hypotension is an adverse effect can happen with any of these classes of medications, because if it does something, then it can probably do it too well if there's too much on board or your body doesn't respond correctly to what that medication is doing. Taste disturbances also, but that's way down on the list. Tests are going to hit you with the cough and the angioedema. Adverse for the blood, we got one here too, just like the ones we talked about with thiazides, hyperkalemia. Your creatinine and your BUN are going to increase. It's expected. Up to 20% is expected. It's going to happen. This is not a reason to stop the drug. It's below that 20%. What does that mean? I got to test your blood. I got to look at the numbers. If I put you on an ACE, when I bring you back in at 4 to 6 weeks, I need to see where you're at. I'm going to do the labs, right? We're talking about lab monitoring. Up to 20%, I'm not going to change you. Expected result. If we start getting really high, so anybody know what normal potassium levels are? 3.5 to 5 milliequivalents per liter, right? 3.5 to 5 milliequivalents. But if we start getting really high numbers, weakness, paralysis, chest pains, and a lot of the same symptoms we saw when we got the potassium too high, right? Or the calcium. But you can get bradycardia with these. I'm not going to ramp up your heart rate. It's going to slow it down. I'm not going to test you on that. We're just going to know that it can cause hyperkalemia. You should have been tested on what the side effects of hyperkalemia or hypo or hyperkalemia were in a different course. But just know, if it starts to get too high, it's dangerous. Weakness, paralysis, bradycardia, pain, numbness. Up to 20%, we're good. Creatinine and BUN go up to 20%, it's expected. So why does that happen? It's because the ACE inhibitors are going to dilate. Remember, we talked about the juxtaglomerular cells in the afferent arteriole. Well, the ACE inhibitor is going to act out over here in the efferent, so the away arterioles. And so it's going to dilate those a little bit, and so that's going to reduce intraglomerular pressure. So that's why you might get a small rise in the creatinine and the BUN. expected and reversible. But there are absolute contraindications to this medication. Pregnancy, do not stop go, do not pass go, whatever the term is. Stop, do not use an ACE. And renal artery stenosis. So either of those two, ACE isn't even a consideration. Absolute contraindications. We talked about monitoring. It's essential. Why? Because we need to know if that potassium's getting too high or how the kidneys are working. About 2 weeks for an ACE, a little bit sooner than your hydrochlorothiazide, 4 to 6 weeks, right? A little bit sooner, only because the adverse effects can much more severe. This is what I was just discussing, the highlights of why ACE inhibitors require extra caution. Pregnancy, no. No go in pregnancy, contraindicated. It can cause fetal renal failure, skull hypoplasia, and fetal death. If you want to know what the actual effects on the fetus are. So even for a female patient, not only are you pregnant or know their pregnancy status, but are you planning on getting pregnant? Right? Stay away from ACE. Drugs interactions are big with these. Potassium sparing diuretics, which we're going to talk about tomorrow afternoon, second hour. And supplements, because we talked about hyperkalemia. Well, if you're also giving them a diuretic with the ACE that's going to keep potassium in, now you're elevating that risk of hyperkalemia, and we talked about it's not good. What can happen? All of those arrhythmias and the different things that people brought up. Classic exam question, right there, the bottom half of that slide, the renal trifecta. Those three things are going to cause you acute kidney injury because it can dramatically reduce renal perfusion. If you start to see the creatinine going up and up and up, patients on an NSAID, they're on an ACE inhibitor, they're on a diuretic, their kidney is injured. An acute kidney injury from the renal trifecta. Diuretics are going to reduce the plasma volume, and it's going to concentrate the blood urine. So it's going to increase your serum creatinine. ACE and ARBs is going to block, like we showed in the little chart, where the ACE or the ARB are going to block the renal compensation, and they're going to dilate the afferent arteriole. And then NSAIDs, which you're going to get block 2, I think, for pain and NSAIDs, they're going to inhibit prostaglandins. So that combination, they're also the NSAIDs are going to limit bradykinin. So that's going to cause vasoconstriction of the afferent renal arteriole. Result, bad on kidney. Renal trifecta. Every test I've ever taken, PANTS, PANRE, it's been there.
So did you say it's the combination of all of these three, or just any one of these three?
Combination. Having them all three on board. Which is huge, right? That discussion, just like we started the video off with, that discussion with your patient. People and patients think that they sell it over the counter, so it can't be bad, right? They don't know what actually that NSAID could be doing to their system, specifically to their kidney, because they have two rather benign, very commonly prescribed medications on board, and then putting that NSAID on board, which they think is just fine because I can get it at the HEB or Walgreens, and no one's the wiser, and they can end up with acute kidney injury.
So for the total ACE diuretic, that and no.
I mean, it's not absolute contraindicated, but you're going to want to watch every 2 weeks. You're going to run those labs, right? If you start seeing the VUN, it's not going to be like, bam, they go into kidney failure. But if you start seeing their blood work show that they're starting to have an effect more than the 20% you would expect from the ACE alone, then you're going to want to start thinking, get the NSAID off, get the NSAID out. I mean, everything's going to be patient dependent too, right? So some patients may take all 3 of those and 10 other drugs in there, but you and creatinine, you'll be just fine. But another patient that's more responsive, and their system is a little more affected by these adverse effects, and that can be enough for them, which may not harm another person. The key is, you're not treating the lab, you're treating the patient. We talked about the numbers, the risk, and also their comorbidities. And then the next piece of that pie is monitoring for all these drugs, because you want to see if we're getting too good of a good thing happening, right? Really, with a lot of these drugs, that's what we're talking about. We're blocking this because that's good for hypertension, but do we get off into a level where we're doing too good of a good thing, and now we're starting to get into adverse effects because we've dropped the volume too low, or we've kept too much calcium on board, or too much potassium, or the opposite, too little. So it's a balancing act. It's more be aware. Ask your patient about over-the-counters, especially when you have them on multi-dose regimens, because often they will come back and say, well, specifically, out in the field, doc handed me 800 milligram ibuprofen and said, take it in my ear. And they just don't relate that there can be side effects from it, right? Let's see where we're at. I think this will be the last slide for today. So if you're looking at this, following it from top, left to right, and bottom left, bottom right, you're just seeing what's happened at the afferent versus the efferent, normal, and then once you start to get decreased pressures, what's happened at the afferent, efferent, and it's just a pictorial of what happens when you have the NSAID and the ACE or ARB on board, and why that compensatory mechanism isn't working anymore, and you have a drop in the glomerular filtration rate. Yeah, we'll save angiotensin 2 receptor blockers and ARBs till tomorrow. I will stay up here if there's any questions, any at all. I know it's a dense material.